Good morning and welcome to the GW Epilepsy Grand Round Series. Please, if you would like to have CME credits, remember to text the 4-digit number which we will give at the end of this talk to the number that we will also give you if you don't have it already, as in previous talks. And I have another announcement for people in the room. Please to turn your phones on silent. And we would like to remind you to register. The registration is open for the Epilepsy Board Review course this July at GW. We have a great number of speakers lined up as per previous years as well. With this, I'm delighted to introduce today's speaker, Dr. Jerzy Szaflarski, Professor of Neurology and Director of Epilepsy at the University of Alabama in Birmingham. Dr. Szaflarski earned his medical degree in Poland and Germany, and then he spent some time in the Silverstein lab at University of Michigan to study the molecular mechanisms of NMDA-mediated neuronal injury. He then earned his PhD from his alma mater in Poland in neuroembryology and pursued his clinical training in neurology and epilepsy at the University of Cincinnati, before spending some time with Dr. Jeff Binder in Milwaukee to learn fMRI, and later with Dr. John Gottman in Montreal as part of his K23 award to study EEG fMRI techniques. For almost 2 decades, Jerzy's research has focused on the mechanisms of plasticity in the brain, especially in the setting of acute, subacute, and chronic neuronal injury, as can be seen by functional neuroimaging. And his long-term goal is to use functional MRI as a diagnostic tool for various neurological disorders and to assess therapeutic response. Another research interest is to study cannabinoids in epilepsy, and he recently co-edited with Dr. Oren Devinsky a special issue on cannabinoids in epilepsy by the journal Epilepsy and Behavior. He has published over 200 papers, many of which are in major journals, and he has spoken at scientific conferences more than 300 times. With this, I'll give the podium to Dr. Szaflarski.
Well, thank you for the invitation and for the introduction. I'm not sure I deserve all these accolades, but because I have way too many slides, we'll just start quickly. I want to start with the title. I don't know how many of you know the titles and know what Quo Vadis means. It's from Latin. It means where are you going. This is a title of a book that was published in 1896 by a Polish Nobel Prize winner, and it was about the development of Christianity. Of course, I stole the title, and I'm using it towards explaining where the neuroimaging is going. So we'll talk about where we were and where we are and where we're going and where we hopefully will be in 25 years. I think maybe 2 or 3 of you have seen parts of this talk in the past when I gave it as a presidential lecture at AES, but this is the much expanded and fuller version of the talk. So these are my disclosures, nothing really relevant. So like I said, we're going to talk about the last 25 years, where we are, and specifically we'll focus on fMRI and EEG fMRI because that's what I've been doing for the last 25 years. And then we'll talk about sort of the new developments. So some of you may remember this. If any of you saw the movie Exorcist, that's sort of one of the scenes when they were getting pneumoencephalograms in the movie. When I was growing up and thinking about becoming a physician, that was the standard of care. In 1970, people were getting pneumoencephalograms when CTs were gradually becoming available. This is a little bit earlier even. This is a picture of the first PET scanner. The person in the scanner is, I believe, Larry Squire, who became then, or later, one of the greatest neuroscientists. And this is his rendition of what he felt like when he was in that PET scanner. Of course, the PET scanners today look a little bit differently, but I want you to remember this picture because I'll show you something similar towards the end of the talk. This is where we were in 1988. This is a very nice, very quick review of the state of knowledge in 1988 by Churchland and Sidnowski from Science. And you can see that of the techniques that we are using today, PET was available, MEG was available, and of course, other microscopic techniques. And with imaging, they were able to find the brain, which was a major feat, without doing the pathological examination. And of course, they were able to identify the system as motor system, visual system, etc. But we were not able to do much more than that at that time. So we have, of course, made some progress since then, and I'm going to talk about where we are now. These are the techniques that are currently available to epileptologists. And again, because of my interest, to be realistic, I could probably spend 2 or 3 hours talking about PET and PET in neuroinflammation imaging. I'll just focus only on structural, functional, and EEG fMRI. But as of today, we can actually, besides finding the brain and looking at the systems, we can create maps. And the maps are actually very useful because they teach us about the brain connectivity and how the networks work. And here's an example of how we use it. This is for language and how epilepsy, we can examine how epilepsy disrupts these connections. This is from a paper we published a few years ago. So again, I'll talk about structural, functional, and EEG fMRI. Let's start with the structural MRI. Why do we get so much functional MRI? Simply, as epileptologists, we want, if the patient fails the first 2, 3, 4 drugs, evaluate whether they're candidates for surgery. And we know that patients who have identified lesions on the neuroimaging have much higher chance of becoming seizure-free after epilepsy surgery if that lesion is resected versus people who have so-called MRI negative epilepsy. So that chance of becoming seizure-free is about 2 to 3 times higher. So it's very important to do everything that we can, everything possible, to identify the lesion. If we don't identify the lesion, the chance of the patient becoming seizure-free is much lower. Before we talk about MRI, we need to introduce a few people. Those are the people who actually made it possible for us to talk about MRI today. It's Isidor Rabai described MRI and NMR in the 1930s, and he received the Nobel Prize in 1944. Then, of course, Bloch and Purcell received the Nobel Prize in the 1950s, and for the younger generation, you actually may remember these 2 names, Lauterbur and Mansfield, who received Nobel Prize in 2003. And I actually scanned a family member of Paul Lauterbur when I was in Cincinnati for research purposes. It was actually a very interesting discussion to talk about MRI and about Paul and the family member who never was in a scanner but wanted to experience that. So a little bit more history. You see that Rabai described a quantum phenomenon called nuclear magnetic resonance in 1937. And then in 1988, 50 years later, he was first imaged with MRI. And his description was, or his impression was that it was eerie. I saw myself in that machine. I never thought my work could come to this. And since then, of course, Ogawa described fMRI that I'm going to talk about. Then, of course, John Ives, when he was at Harvard, described EEG fMRI. And then the French group with Le Bihan described DTI. This is one of the first images that I ever collected. This is DTI of celery stick. This was 1990s, 3 Tesla Bruker scanner at Cincinnati Children's. And we were experimenting with the technique. So we made a little bit progress since then. This was early 2000s when we were doing tractography. And this is actually from last week that we collected on a healthy control. We have a multi-center study, and this was a subject from Brown. And we processed it in Cincinnati, and we can use this to look at white matter tracks in the brain. This is one of the first MRI pictures ever published. And I don't know how many of you have ever seen this picture, but this is from 1986. Montreal Neurological Institute, 0.5 Tesla MRI scanner. This is the first published that I'm aware of, a picture of mesial temporal sclerosis here on the left. This is from the book by Jean Gottman, Ruben Kuznicki and Jerem Jackson. And of course, we get MRIs routinely, but we get them in 3 situations. Somebody with new onset seizures, and I'll tell you in a second why this is so important. Someone who has long-standing epilepsy, and we still see these patients who never had MRI. In 2018, we still see these patients. Why? Because they started having seizures 40, 50, 60 years ago, and at that time imaging was not so readily available and nobody ordered these scans. And of course, when we do pre-surgical evaluation to look for the lesions. This is on the left, you see the standard protocol that we get on everybody, and on the right you see a little bit more advanced protocol, things that we get on our patients when we are looking for a lesion where the first scan is read and reported as MR negative epilepsy. We order all these techniques or select some of them specifically to look for either white matter tract injury or other pathologies. So what findings do we expect to see? In medial temporal lobe epilepsy, of course, nothing unusual. You expect to see hippocampal sclerosis that has three crucial findings, which is the typically seen reduced volume, there is increased T2 signal, and the third finding is something that people typically pay less attention to, is the abnormal morphology or loss of internal architecture. In neocortical epilepsy, of course, the findings will depend on type of epilepsy and location of seizure onset zone. So some of you may think, well, we know structural MRI. Why do we need to talk about structural MRI? Well, you can still do a lot of interesting things with structural MRI. This is a paper that was published on Friday, so 3 days ago, in Brain, and looks at about 2,500 epileptic brains, or brains of patients with epilepsy, looking for specific findings, specific abnormalities. You can clearly see here, this is left temporal lobe epilepsy, and the areas in color are areas that are atrophied in these patients compared to healthy controls. So you see large areas of brain atrophy, although the MRIs were read as normal. This is right temporal lobe epilepsy, and again, you see a lot of brain areas that are associated or they're atrophied in these patients. And this is on the right. You actually see, you take all patients with epilepsy that they enrolled in that study compared to healthy controls. And again, there are multiple areas of the brain, including precentral cortex, that is somewhat atrophied in our patients with epilepsy. Although on routine MRI scans, when you take one scan at a time, you'll never capture that. So structural imaging is still very important. Of course, when we sometimes see a new patient with either new onset epilepsy or somebody who has never been scanned before, you find things like this. So bilateral heterotopia in somebody who is otherwise completely normal, has job, drives, or doesn't drive anymore because the seizure started, but has normal life, and you find findings like this, you are still surprised and mesmerized by the fact that with such huge abnormalities, they can function just fine. Of course, sometimes we see this. This is a MRI of a patient of mine who came to me with a diagnosis of TS. Graduated from Auburn, is a computer specialist, plays golf, is actually a scratch golfer, is doing very well, and you see multiple tumors in his brain. He's seizure-free after we implanted RNS over that lesion that was generating the seizures and was not resectable because it was motor cortex. Another patient with very small cortical malformation in occipital cortex. This was read as normal for years and years and years. She had multiple MRIs that were as normal until we looked very carefully at the correlation between the MRI and the EEG. So, in new onset epilepsy, when you order an MRI, what should you expect? And there's actually a great study from a few years ago in neurology, some of you may have seen it, that looked at new onset seizure clinic in Australia. And they had about 1,000 and few patients in that cohort. A few turned out not to have new onset epilepsy, so they excluded them. But in the end, 993 patients with new onset seizures or seizure-like events were enrolled. And as you can see, only 77% of them were able to get MRIs. The rest did not get MRIs for one reason or the other. And in those who received the MRI, 23%, so a quarter of them, had lesions that were potentially epileptogenic. So whether it was a brain tumor, encephalomalacia, what have you. So 1 in 4. But when you narrow it down to patients who had likely focal onset seizures, half of them had lesions. So really you need to pay attention to this. If you have somebody coming with new onset seizures, they really need an MRI to rule out any type of intracranial pathology. But even in patients who had non-epileptic events, and I'm not talking about non-epileptic seizures, whether this was a syncope or any other type of event that was suspicious for seizure, 8% had lesions. So there is some increased incidence of lesions in patients who have neurological events. Of the lesions, of course, about half of them were encephalomalacias. But what's interesting, of the remaining patients, about 22% had non-epileptic lesions. So whether this was venous angioma, whether this is the UBO that we see so frequently. So in total, 45% of patients with new onset events had lesions of sorts. And it's very clear when you look at the AAM guideline that was published now 3 years ago by Alan Krumholtz. You'll find one important thing. There's one little paragraph that has maybe 4 or 5 lines in it that talks about neuroimaging. And you can clearly see that somebody who has lesion on an MRI has about twice the chance of continuing to have seizures or having more seizures than someone who has completely normal MRI. At 5 years after the first seizure, the chance of having the second seizure is 50% in someone who has lesion versus about 27 or 28% in someone who has normal MRI. So again, it's very important to identify these lesions because we can be either more aggressive with the treatment or be more aggressive with further evaluation towards epilepsy surgery. This is the guideline from American College of Radiology, and you can see this is in new onset seizures. Really the useful test is the MRI with and without contrast, with CT being second best. And then the rest is really not important for new onset patients. So we sometimes see patients who had SPECT for new onset seizures. I'm not sure exactly why someone would order it, but it's done. And this is not felt to be useful at all. So when we have the patient with new onset seizure, you already know that if they have had first seizure, had second seizure, third seizure, you place them on medications, and they're failing the third medication, then the chance of them becoming seizure-free with anti-seizure medications is very minuscule, maybe about 8% or so. So about 30 to 40% of these patients who have new onset seizures will never be controlled, and they should be evaluated for the diagnosis of treatment-resistant epilepsy and geared towards surgery. Another look at this is through the eyes of Frank Samat. This is a paper published 20 years ago now. They looked at 2,200 MRIs of patients with epilepsy, and they looked at what type of pathology was associated with what type of seizure control. And the easiest to control, so to say, were post-stroke seizures, and the hardest to control were patients with mesial temporal lobe epilepsy or patients with dual pathology who had some kind of lesion like cavernoma and mesial temporal sclerosis. Of note, some of you know, this is the population that is probably the easiest to treat surgically. Also, the location of seizure onset was predictive of outcomes, with temporal lobe epilepsy being the most difficult to control, and then, of course, frontal and other epilepsies being somewhat easier to control. So we are at the point of referring the patient to epilepsy a physician and evaluating for surgery. Why do we do that? This is a very nice review from Barbara Jobs and Greg Cassino from JAMA from 2 years ago or 3 years ago, looking at this. The chance of becoming seizure-free with epilepsy surgery is about 64%. The chance of becoming seizure-free with medications is 8%. This is the 8% is from Sam Weeb's New England Journal of Medicine trial. And these are the data. This is Sam Weeb's data, 8% chance seizure freedom with medications, 50 to 60% chance of seizure freedom with surgery. This is from Pete Engel's ERSA trial, so early epilepsy surgery trial. The data are exactly the same. They needed only about 38 patients to show significant difference between groups in seizure and quality of life outcomes. And this is from about a month ago. Published in New England Journal of Medicine. This is a epilepsy surgery trial, a single center in India, and they took children with neocortical epilepsies, randomized them to medical therapy versus epilepsy surgery, and the results are basically the same. 77% of children who received surgery were seizure-free, and 7% in the medication group. So again, case for epilepsy surgery. And this is the surgical planning from American College of Radiology. And again, the techniques that are on top of the list are MRI, but as you can see here, the PET made it to the first top 3. And then, of course, you have functional MRI that is felt to be useful in majority of the situation, and MEG is very useful in some patients as well. So we've been through this slide before. Again, 2 to 3 times higher chance of seizure freedom after epilepsy surgery. But what to do when you have MRI negative epilepsy? So those patients who you look at the MRI, the radiologist looks at the MRI, and no matter what you know about the patients, you can't pinpoint the lesion. There are multiple other techniques that we frequently use, whether this is high field, high resolution MRI, or whether this is MR spectroscopy, or actually processing of the data in a little bit different way. Instead of using your own eyes, using the computer. So high field, high resolution. I wanted to show you some images from a colleague of mine. He's next door in our office is Larry Verhoff, and he developed this technique called HI Micra. It allows for very high resolution, fast imaging of the brain. We get this is an image of the brain obtained in about 4 minutes, and hopefully it will play. So you can see the exquisite internal architecture of the hippocampi, anatomy, and the symmetry. Of course, there's no signal change here. This is a normal hippocampus. And in all honesty, I have no idea who the subject was, but they had very nice looking hippocampus. And this is a close-up of the same hippocampus. You can clearly see beautiful symmetry and anatomy of the hippocampus. And this is 4 minutes. It can be implemented in any scanner in just half a day of programming. And this is the same technique at 7 Tesla. In all honesty, I see a little bit of improvement after looking each time at these scans. The resolution is a little bit better than 3 Tesla, but it's probably clinically not as relevant, but we get beautiful, if it plays, we get beautiful anatomy of the hippocampus as well. This is a very large file, so sometimes it doesn't want to play well. This is an example of a MRI negative epilepsy with standard MRI that we actually did the HI Micra on, and you can clearly see, I want you to pay attention to the right hippocampus right here and look at the difference. Now, in retrospect, looking at the standard MRI, I'll say, well, maybe there is something, but we never wanted to call it because we were not convinced there was anything. I'll play it again. Right here, you see, when you compare the hippocampi, there's a little bit of change in the internal architecture. So this made a change. For this patient, we were first thinking about doing intracranial monitoring because it was normal hippocampus. After obtaining HI Micra, we simply did the temporal lobectomy. The patient is seizure-free. So the imaging helped us change and streamline the evaluation and treatment process. Here, some centers get 7 Tesla MRI. This is from Julie Pan, who probably has been on the front of high field imaging for the last 20 years. And you can clearly see the same patient image at 3 Tesla, and you see this very clear band heterotopia here. And you clearly see that it's probably a little bit easier to see here at 7 Tesla. Julie uses another technique called multivoxel MR spectroscopy. So multiple small voxels around the whole brain to identify areas of metabolic abnormalities. This is a patient, they operated on somebody who had normal MRI, as you can see here at the bottom, and then on top is the MR spectroscopy with one area of metabolic abnormality around the mesial frontal region. That area was eventually resected and the patient is seizure-free. And it was not actually a normal brain tissue, but only the MR spectroscopy was able to visualize that. Of course, besides, I'm sorry?
Is that a whole brain MRI?
This is whole brain MRI, it's multivoxel spectroscopy, yes. Of course, we also process the data in different ways. We started doing this maybe 3 years ago, but some places have been doing it a little bit longer. Morphometric analysis of the brain or map is basically voxel-based morphometry compared to a matched template. So this was the study that actually put it on the forefront. This is Irene Wang from Cleveland Clinic, looking at 150 patients with so-called MR negative epilepsy who were operated on, who had surgery, who had resection, and their MRIs were read as normal. With the map, she identified that about 43% of patients actually had lesions, had abnormalities, typically a small malformation of cortical development. and the resection of the area that identified by MAP was associated with improved seizure outcomes. And I'm sure Dr. Kobeshi actually participated in evaluating some of these patients a while ago. So we have implemented this. This is one of the patients that we actually sent to Cleveland Clinic. He was a faculty at UAB, so it was probably just best to send him away for evaluation. And this is his imaging from UAB. And in that retrospect, yes, I see maybe a little bit of sort of loss of the gray-white matter junction here, but this is in retrospect what I know exactly what the patient has. Initially, it was read as normal. His 7 Teslas imaging was also basically read as normal, but when we did the template comparison, this is what came out. This area of abnormality, that area was resected a year and a half ago. The patient is seizure-free and still on faculty. This is another example, someone who came to us about a year and a half ago, had surgery at another center, was seizure-free for a brief period of time, and then seizures recurred. We took his post-resection MRIs and did MAP on them. We thought that there was maybe a little bit of abnormality in the right insula. We probed that, resected that, turned out to be malformation of cortical development. The patient is seizure-free. So certainly doing this has helped us tremendously in identifying patients who benefit from or may benefit from epilepsy surgery. So just to summarize, the structural imaging. There are many patients with MRI negative epilepsy, about 50 to 60% of them. We have newer techniques that help us evaluate these patients. But the data that we have are typically from small single center studies, retrospective studies that use a very esoteric technique that is very difficult to implement in other places. The one technique that I found very, very helpful is MAP. We have implemented that, and I think every center can implement that. It takes maybe half a day of sort of working with voxel-based morphometry software to use that identify lesions. And I'm sure that in the next few years we'll have more either imaging techniques like HI micra or data processing techniques like MAP that will be very useful for us. Functional MRI, so something that I've been doing since late 1990s. And at the time that we were implementing fMRI, of course, we were using it for language lateralization, localization, and since then there are some memory studies, and of course it can be used for mapping of any type of eloquent cortex. And finally, the EEG fMRI, which is in many ways a holy grail. So here you have examples of patients with epilepsy. This is data that we collected a while ago with the picture encoding task or scene encoding task, 2 names in the literature. Here you have 2 patients with right temporal lobe epilepsy, and the right temporal lobe is devoid of signal, while you see very nice activation in the left temporal lobe when the patient is encoding the pictures. Again, here is a right temporal lobe epilepsy patient, and activation predominantly is on the left, and here you have a left temporal lobe epilepsy patient, and activation is predominantly on the right. So with this task, we can actually lateralize the memory encoding in patients with epilepsy. And in healthy controls typically is very symmetric. But we always wanted to replace the water test with fMRI because water test is like this 4T, very old technique that at some point can fall apart and not necessarily help us or potentially even injure the patient because there's a 10% chance of complication. So, of course, we prefer to replace it with something much newer and nicer. But it's not just replacing one car with the other, one technique with the other, because it's a completely different paradigm shift. With intracarotid amobarbital procedure, you have injection into the cerebral circulation that potentially can cause a lot of problems. Here we put someone in a scanner, that's actually me in a scanner, getting fMRI of language, and you see the nice activation, localization, and lateralization of language functions. And that's a simple comparison of the gold standard, which is the intracarotid amobarbital procedure, and today I would call it a bronze standard because radiologists don't like it, neurologists don't like it, and we really would like to or prefer to use fMRI to evaluate language and memory lateralization. But there are issues with fMRI, and it's not a technique that is perfect. There's of course chance of false lateralization. There is also problem with how you process the data. And this is a title of a paper by David Loring, published in 2002. David is one of the most well-recognized names in epilepsy neuropsychology, and he processed data at a different threshold, and sometimes you saw the activation, sometimes not. So it's very important to make sure that these things are standardized. So what do we do with fMRI? Well, we collect some raw data, we do some processing of those data, slice time corrections, template matching, etc. Take some kind of block design, hemodynamic response curve. Typically it's a block design task. Fit in with the bolt signal changes, so you have the bolt signal, the curve, the bolt signal changes, how they fluctuate with the task. We have active and control conditions. You fit in the task regressor. This is what it typically looks like, and you get the activations in the brain. Some areas show increased bolt signal, some areas will show, of course, decreased bolt signal with the task. And the task that we use here is the semantic decision, tone decision task. This is probably one of the most well-recognized tasks in language lateralization in epilepsy, developed by Jeff Binder in early 1990s, and it's still in use, and we thus far have not been able to find anything better. This is what the task is. Active condition is semantic decision, so the patient or the subject needs to decide whether the animal lives in the US and is used by humans. And in a control condition, it's hearing tones and deciding whether there are two high-pitched tones or not. It very nicely correlates with the WADA test. And you can see here that the correlation is great. This is again from a paper by Jeff, published more than 20 years ago now in neurology. And this is sort of summary of all the data that are available right now in literature. People stop publishing this because there's so much that nobody wants to write another paper about the relationship between fMRI and WADA test. But you can see here that there is a little bit of discordance. In the early papers, the top 4 or 5, those were very, very early papers. They had no discordance because the evaluation was based on, I see it's predominantly on the left, and the WADA test was left, so they are in agreement. The later papers actually have larger numbers of patients. So there are patients that have sometimes bilateral language activation, and these are the patients that most likely show discordance between one and the other. So the discordance is about 15%. And we really don't understand why there is discordance, and if there is discordance, which one is better, the WADA test or the fMRI. There's hint from this one study. This is again from Jeff Binder's lab, looking at the 10 discordant patients that they had in their data of more than 200 patients, and you can really see that in 3 patients out of the 10, WADA test predicted the verbal memory outcomes better than fMRI, but in 7, fMRI predicted better than WADA test. But we still don't know why somebody belongs to the group of 7 versus the group of 3. So we still need to sort it out on much larger groups of patients. We also know that temporal lobe epilepsy surgery is associated with typically with verbal, if this is dominant temporal lobe, verbal memory decrease in these patients. And this is a longitudinal study published a number of years ago, looking at the decrease and then stability of the signal over time. So we need to be able to predict in our patients who will or will not develop the language deficits after surgery. And that's where the neuroimaging, verbal memory deficits after surgery, and that's where the neuroimaging comes into play. This is again from Cleveland Clinic. Robin Bush published this. This is really nothing new, but this is the largest sample ever published of 875 patients who had temporal lobectomy and who had WADA test and language testing or Boston naming test before and after surgery. And you can clearly see that if you operate on the left that is dominant, the chance of verbal memory deficits is about 40%. But if you are over 50, that chance is 75%. So it's a very high chance, and you need to advise your patients accordingly. But you also would like to know who is in the group of high risk versus who is in the group of low risk. So I just mentioned that. This is the task that I showed you pictures of in the beginning. This is a memory task or scene encoding task. I showed you the activations in the mediotemporal structure. Again, this is a block design task where in the active conditions the patients see pictures and are asked to memorize them during the scanning procedure, and the control condition is just controlling for the attention to the task. There are about 200 patients who are in the literature described with this task, including 91 with left temporal lobe epilepsy. What it turns out is that this task has very nice correlation with the neuropsychological performance, a very strong correlation, but it has very weak correlation with the results of water test, and it does not predict long-term outcomes. There's in fact one study that compared semantic decision tone decision task to this memory encoding task or scene encoding task and showed that the semantic decision tone decision task is much better at predicting verbal memory. So we have abandoned this task, and I don't think many patients were scanned with this task in the last 10 years. But it allowed us to learn a little bit about designing the tasks for these patients. And here you have a comparison of the semantic decision tone decision task to WADA test, showing that fMRI has 100% sensitivity and 75 to 73% specificity of predicting verbal memory outcomes after epilepsy surgery, and that sensitivity and specificity for WADA test is much lower. So there are two other studies that I'd like to mention because those are studies that look at memory outcomes with fMRI. Both were published in the last few years by the London group. The first one is Silvia Bonelli, looking at 44 temporal lobe epilepsy patients with covert word generation tasks. So covert meaning that they are not recording the responses, they don't really know what the patient is doing. And it's a letter work task, so they are given a letter and they are supposed to generate words associated with those that start with that letter. So, you know, if you hear B, it will be bone or something like that. But they have no way of really monitoring these patients. What is important is that since this is a language task, really not a memory task, they observed that stronger prefrontal activation on the left was associated with greater post-resection decline in naming, and the stronger activation on the right after resection was associated with better naming performance. So these are sort of their data. Again, not unexpected language task predicting verbal memory outcomes. This is the same as Jeff Binder's data with semantic decision tone decision. They also developed a little bit different task that is much more of a memory task. The patients are asked to covertly memorize presented concrete nouns. So while they are memorizing things, they are being scanned, sort of like the picture encoding task, except that they have written words instead of scenes. And what you can see here is that stronger pre-resection activation in the left frontal and in left anterior temporal head regions was associated with greater post-resection memory decline. So if you activate left, you have much higher chance of deficits afterwards. And activation on the right had no relationship between the fMRI and outcome. So why is it important to obtain this activation in the temporal lobe? Well, because with temporal lobe, we do temporal lobe resection. With temporal lobe epilepsy, we do temporal lobe resection. This is the extent of resection that the neurosurgeon does. Typically, the resection is a little bit more conservative on the left, and many surgeons will not necessarily resect the superior temporal gyrus, but in general, this is the gist of things. So when you look at the fMRI activations, and here on top, in the middle, you have the activation with the semantic decision tone decision task. You see that the activation, which is in green, overlaps only a little bit with the area of resection. So although it is fairly predictive of the outcome, we can probably develop something better that activates more of the temporal lobe. So I think in 2010, Jeff and a few others of us worked on a task that is story versus math. We have enrolled 250 patients or so into a study that had a pre-surgical fMRI with this task, because you see beautiful activation and very substantial overlap between activation with this task and the area of resection. So in the end, The outcomes, surgical outcomes, were as expected. About 70% of patients were seizure-free. That's what you expect from temporal lobectomy. And we're hoping that we'll have the fMRI results sometimes this year. So there's now practice guideline. So we actually have enough data to create a practice guideline that talks about using fMRI in epilepsy surgery. And you can clearly see from that guideline that there's very strong evidence for using fMRI for language lateralization and for predicting verbal memory outcomes. But for other outcomes, it's not as good, and we still need to work on that. One last word about functional MRI. This is the future. This was a paper published last year in Epilepsy. They had 36 patients with new onset seizures. They obtained resting state fMRI on these patients, so no task fMRI, just resting state. And we're able to predict who will develop seizures later, or who will have more seizures later versus who will have one single seizure. The interesting part is that the abnormalities that you see here, and they're sort of the arrows, match very nicely with the abnormalities that are observed in patients with epilepsy in the study by Whalen that was published last Friday. So the interesting part is that maybe there is something pre-existing in those brains that will lead to development of epilepsy, because based on this finding, you can clearly see that there's an overlap between new onset epilepsy and the patients with chronic epilepsy. So again, functional MRI, what is missing? And what is missing is a lot of things that are nicely outlined in the guideline that create sort of a road map for future research with fMRI in epilepsy. So finally, functional EEG fMRI. So as you know, with MRI, we look for the brain. We want to find it. We want to make sure that the patient has the brain. With functional MRI, we need to localize the important functions in the brain that we don't want to interfere with when we do the epilepsy surgery. And with EEG fMRI, we sort of want to find the association between EEG changes and brain activation. Here with spike and wave discharges in this cartoon between thinking and activations. And of course, no, I tell my patients we cannot read their thoughts when we do the EEG and fMRI combined. Why do we want to do simultaneous EEG and fMRI? There are multiple reasons for doing this. In health, we can look at alpha rhythms, we can look at sleep waves, we can look at normal activity, normal evoked potentials, etc. In epilepsy, we really want to implement this in pre-surgical evaluation. So in those patients who are MRI negative, we can identify the areas of the brain that show increased bold signal changes or bold signal changes and hopefully resect those areas. So this is, for example, what we can do with in normal patients or normal controls. We can look at their alpha rhythms and see the power of alpha, so whether you have a lot of alpha versus little of alpha, how it correlates with resting state. This is something we published just a few months ago looking at these correlations. So you can do a lot of things with EEG fMRI, but the most important thing for us as epileptologists is to look at the metabolic changes that occur with spike and wave discharges. So this is how we looked at the data. This is an EEG of after removing all the artifacts that are associated with scanning. You can clearly see that there is generalized spike and wave discharges with bifrontal predominance. This is a patient with generalized epilepsy. Again, we fit some kind of hemodynamic response curve, and we obtain some nice images of the brain with areas of the brain showing increase in bold signal and areas of the brain showing decreases in bold signal. Here's a study from Hal Blumenfeld, published in Journal of Neuroscience a number of years ago. Those are patients with absence seizures. You can clearly see areas of increase in bold signal and in decreases in bold signal. Especially of interest is the increased activation in thalamus. And this is, of course, the bold response curve, and you can see multiple areas show different bold response curves. Here's some of our data looking at the patients with generalized epilepsies who are or are not resistant to valproate. You know that patients with generalized epilepsies should exquisitely respond to valproate, with the original studies reporting about 90+% responder rate to valproate. So when the patient does not respond to valproate, you of course are questioning what is going on. And when you compare these patients, you see there are multiple areas of differences in activations. These are the regions that had very different activation patterns between those who do and don't respond. Thalami, putamen, insular cortex, and paracingulate. And when you look at this bold signal response curve, you can see that the bold response is first in paracingulate gyrus, and the other three areas are actually delayed. There is actually now nice neuroimaging data from anatomical studies showing that as a group, patients with generalized epilepsies have some structural abnormalities in the paracingulate gyrus. There are some studies showing, of course, insular changes on other areas, but this supports that although generalized epilepsies, we see generalized spike in wave discharges, they probably are not necessarily generalized. Here is a analysis again of our data looking at the thalamus and connectivity with the paracingulate gyrus, and you can see that there are different interactions between different thalamic nuclei and paracingulate cortex. Show some of the nuclei show positive and some of them show negative connectivity with thalamus. And that plays nicely into data that Jean Gottman published a few years ago looking at the interactions between thalamic nuclei, showing that the signal is probably transmitted from one nucleus to the other in thalamus. So, of course, we want to do it in patients with focal onset epilepsies and use it for epilepsy surgery evaluation. Here's an example of a patient that was captured in MRI having a seizure. This is again after removing of the artifacts. You clearly see ictal discharge lasting about 9 to 10 seconds coming from the right temporal lobe, and the activation related to that. The patient had surgery, had this right temporal lobe removed, and then seizure free. Of course, this is a very simple thing because patients with temporal lobe epilepsy will have a high chance of seizure freedom after surgery anyway, especially if they have mesial temporal sclerosis, and that was the case here. But we need to look at these patients who are non-lesional and see whether there is something that we can use in functional MRI, in EEG fMRI to predict the outcomes. And there are several studies now to that effect looking at various types of outcomes. And as you can see, those are really small studies. But most important thing out of those studies is, and those are non-lesional patients, that if you identify both signal changes related to the spike and wave discharges, and they are relatively focal, and that area is removed, then the patient has much higher chance of seizure freedom than if the bold signal, the primary bold signal change is not removed. And actually, last week or so ago, Jean Gottman took it to the next level when they had analysis of 25 patients out of about 60 or 70 that they enrolled who had interictal epileptiform discharges on EEG fMRI and then exploration with SEEG. And they looked at high-frequency oscillations. And in those patients who had one very nicely delineated area of primary bold signal change related to epileptiform discharges, typically there was an increase in high-frequency oscillation, or the very high-frequency oscillations, about 250 hertz in that area as well, indicating that there is some relationship between those changes and the bold signal changes. They did not report on a surgical outcome of those patients, although I suspect these patients were enrolled in these other studies that they already presented. So again, what are we missing here? Well, we are missing, again, multi-center randomized trials. There are truly two centers that look in some detail at patients with focal onset epilepsies. That is Montreal, Jean Gottman, and the London group, and Australian group is starting to look at that. And there are other places that are collecting EEG fMRI data like us, but we have not reported on that. We just don't have the big enough samples. So this is where we are today. And in a corner here on the right, you see where we were 30 years ago. And you see that this graph, this figure is much busier than it was 30 years ago. We have new techniques that didn't exist at that time. Of course, the PET imaging has changed dramatically. The lesion symptom mapping has evolved too, because there are now new ways of analyzing the lesion symptom data in comparison to what we had about 30 years ago. So a lot of change in that field. And the question is, of course, where are we going with this, and where will we be in another 25 years? So just a few words about these few things. Sequence development, data processing, hybrid system, higher fields, portability, and therapy delivery. So of course, the improved sequences, I showed you MICRA. There's another technique that is being developed currently, the GluCEST, which is a chemical imaging. It's available at 7 Tesla. Actually, 3 centers are doing this. It was originally developed by scientists at UPenn, and now I heard Australian group is using it, and we are using it in Birmingham to look at the glutamate in temporal lobe. And this is what the imaging looks like. You see differences between left and right here in a patient who has temporal lobe epilepsy. So this, we may take it in further in the future, and hopefully if this really pans out to be such a good biomarker for detecting the temporal lobe epilepsy, we may be able to do something more with this technique. Data processing and merging techniques show, of course, machine learning algorithms. We all heard about the machines replacing radiologists or neurologists in deciding what the patient has. I don't think it's going to happen, or at least not in the near future. But yes, we'll have data processing software packages that will process the imaging data for us, and will hint towards the abnormalities that then, in the end, we'll need to verify whether they are there or not before we make the decision. So I don't think the radiologists have to worry about being replaced by machines, at least not today. And of course, connectivity on us. We talked a little bit about this last night at the dinner. And there are now several studies. The two that I really like is one by Leo Bonilla from 2015, where they took and looked at connectivity of the mesial temporal lobe that was to be resected, and the connectivity or lack thereof predicted the outcome of epilepsy surgery. And another study published last year by the Jefferson group looking at thalamic connectivity, and it also was able to predict epilepsy surgery outcome in temporal lobe epilepsy. One thing is building the networks and understanding the connectivity of the network. Two is maybe finding out what the nodes of the network are and modifying those networks, those modes, rather than the primary seizure onset site. And if we can do that, maybe we can affect the ictal onset zone and either decrease the seizures or stop the seizures and avoid doing the epilepsy surgery. Again, in a few years, we may know a little bit more about that. Hybrid systems, it's in many ways, that's sort of a holy grail to build machines that can do multiple things at the same time. And of course, the hybrid PET MRI has been around for a number of years, and we are gradually starting to implement this in epilepsy, especially when we're looking at neuroinflammation. And as you know, about 10 to 15% of patients with epilepsy have epilepsy related to neuroinflammation. It improves the resolution and gives us additional information. Hybrid MEG and MRI, again, these scanners have been developed already. They are very low field, but with improvements in technology, hopefully we'll be able to get to higher fields. And hybrid SPECT MRI, this is mainly for research, but yes, it's available. You can get both, and this is for studying of animals. I'm not entirely sure how it will be utilized if humans, if at all, but the time will tell. Higher field, we talked about 7 Tesla, whether this is for anatomical or chemical imaging or metabolic imaging. We probably will go at some point to higher fields, maybe 8, 9, 16 Tesla. And it probably will be better for metabolic imaging. It may improve our structural imaging as well. But again, time will tell whether we can get there. I believe we'll be doing more 7 Tesla imaging in the future, at least in the next few years. And 7 Tesla is actually now approved for clinical use. So I ask you to memorize the picture in the beginning of Larry Squire sort of envisioning what he looked like in the PET scanner. And this is actually reality today. A friend of mine, Julie Brevchinsky, is imaging people with a portable PET scanner. They're walking around and they get imaged when they have their absence seizures or what have you. They're developing multiple tracers. for this ambulatory PET. The other portable device is wearable MRI. The group in Switzerland has taken to the next level. This is the wearable MRI, and this is the image of the pineapple here. Of course, it will take a little bit longer to take it to a human. When I was still in Cincinnati, we were developing wearable MRI coil. This is a 28-channel coil. Towards the end, when I was there, we developed a 168-channel coil that was a little bit more moldable than this one, and we were getting very nice images from the wearable coil. And then therapy delivery. So, of course, this is MRI-guided therapy. The medication or therapeutic is tagged with nanoparticles and targeting ligands, so it can go to the tissue that you want it to go to, and then the MRI can, if you MRI the patient, it will release that therapeutic. It's been used now in cancer therapy, and hopefully sooner than later we'll use it for epilepsy therapy. So this is where we are today and where we're going. Thank you. Sure.
One apparently from a patient asking about the reasons for failure of temporal lobectomies, despite concordance of data.
We still don't know why some patients fail. There will be patients who will fail. Again, the chance of epilepsy surgery helping the patient is somewhere in 80 to 90%. 70% seizure freedom. But again, there may be other abnormalities in the brain that we are not identifying today that may cause the patient to have seizures, and the temporal lobe epilepsy may be secondary epilepsy. So not removing the primary source can lead to failure.
Thank you. The other question is about whether you're aware of any studies that used EEG fMRI to diagnose primarily sleep disorders.
There are studies looking at sleep patterns, but I am not aware of any studies specifically looking at diagnosing sleep disorders. I don't think we are there yet with EEG fMRI to diagnose anything. We're just studying the various types of disease processes. At some point, we may be able to look at the activation pattern with bolt signal to see whether this is characteristic for something, but I'm not sure we will be able to ever use EEG fMRI to diagnose anything.
Thank you. Any questions?
So I think I saw one slide about like the function MI and the memory coding. Mm-hmm. So in that slide, I think if I remember correctly, like if you saw like the frontal activation during the memory tasks, and if frontal activation, that shows like the temporal lobectomy, like the outcome is good. I think it's afterwards. Next. Yeah, this one. So if the function activation, frontal activation, then the hippocampus, the hippocampus activation, it's better outcome, or it's kind of
okay. So there are three messages here.
Right.
First message is if you have stronger pre-resection left frontal and LTA activation, there is a greater post-resection verbal memory decline. So activation on the left before surgery predicts poor outcome. Right. Second is bilateral posterior hippocampal activation, there is less post-resection verbal memory decline because you have activation on both sides. So the other side that you're not resecting is probably able to take over the function of the resected hippocampus. And the third one is if you have just activation on the activation on the right, present or not, will not predict the outcome.
But sometimes we talk about like a co-dominant, like a bilateral hippocampus dominant, and we kind of assumption is like even it's co-dominant, we do the resection, they will still have some decline.
Correct, but these patients will probably have less decline. If you have bilateral activation, the patient, it's a bilateral representation of memory, the patient will have less decline if somebody who has only left-sided activation who you resect.
And another is about the anatomy of the MRI. I think like the radiology, the guideline, like the first one is MRI with and without contrast. So what's the role of the with contrast here?
It probably allows to, especially if you have a lesion, to decide whether this is a static or growing lesion. And the other thing is, if the lesion is very small, even if it's starting at the new onset seizures, then probably with contrast will be easier for the radiologist to visualize that. I think this was somewhere.
Yeah, that's
right here.
I think you showed a slide about predicting the development of epilepsy after a new onset seizure using fMRI. So how much work?
That
is it just that's pretty like new, right?
correct. That paper was published last year, right here.
Because there's a lot of interest in it these days, and I wonder how useful or how much this is going to develop, fMRI being used to predict who will develop epilepsy after, say TBI, whatever.
Correct. So this is the first study of that kind published last year. It took them, I think, 3 years to collect these data when you present with new onset seizures. So again, there may be other studies that are doing exactly this, but they have not been published yet. There are studies looking at resting state and traumatic brain injury and whether they can predict seizure outcome. There are studies already showing that the resting state fMRI can predict cognitive outcomes. So somebody who recovers better than somebody else. But I don't know of any studies published looking at seizure outcomes, but I know that there are studies that are collecting these data.
So in your center, when you do like a fMRI with a memory task, what exactly you do?
I'm sorry, can you say it again?
So in your center, when you do the fMRI with a memory task, like a memory task, what exactly you do?
We used to use the picture encoding task or scene encoding task, but we realized that as good as the correlation with the neuropsychological testing is, it does not predict the outcomes. So we now switch to the SEED-WHO task. This is this task. And we're starting to collect data on this task. But again, remember, we do a fair number of surgeries, about 60 surgeries a year. Not all of them are temporal lobectomies. It's going to take a while before we collect the number of data to even replicate this study. This is from John Duncan, yes.
All right. Thank you.
Great, thank you.